Today we focus on the intraoperative portal ground and how to put the intraoperative portal vein stent. So as we know, to keep the adequate portal inflow is very important for the liver regenerations. Too much portal flow will damage the hepatocyte and maybe induce the small force size syndrome. But too inefficiency portal flow may be induce the portal vein thrombosis, and the large collateral veins can cause the portal vein stale phenomenon, and then maybe too slow portal inflow. So today we want to make sure the adequate portal inflow, so we will do the intraoperative portal ground. Actually, we will identify the portal flow duration, because after the liver transplantation, we need to keep the right duration of portal inflow, and after the pectomy, we need to identify the quality of a portal vein. And finally, after the anastomosis, we need to identify the adequate portal inflow after anastomosis. So today we will show the case. This case is a 64-year-old male and pre-liver transplantation, which we can see it's a totally occlusion of the portal vein and the splenomesenteric junction and a large coronary vein. After that, like this case, we will do the portal vein intraoperative portal ground. The first one, we can make sure as the flow still can go into the splenomesenteric junction, and maybe a small stump above the splenomesenteric junction. And then we will measure the pressure gradient. Pressure gradient with mesenteric system is 25, and we measure the IVC is 7. So it shows a high pressure gradient and compatible with portal vein thrombosis. And then the surgeon maybe use the put-out technique to inversion the thrombectomy. And after thrombectomy, we will make sure the portal flow is still good. And then they will do the anastomosis. And you see that after anastomosis, we will recheck the portal quality again. And it shows a good hepatopital flow into the liver and a good velocity. And then we will do the sonography to make sure the portal inflow is adequate or not. And if it is adequate, if any wrong, like a poor inflow or insufficiency portal flow, at that time we will do the portal vein stent to help to improve the portal inflow. And that time we also can measure the portal pressure gradient. The mesenteric portal vein is 17, and the IVC is 5. Our goal is to keep the pressure gradient is below the 15 millimeter mercury. And then after that, we still is a good quality of portal anastomosis. The second things they want to close the large mesenteric portal mesenteric shunt, mesorenal shunt. At this time, they can identify the large shunt, and then they close the shunt and recheck the portal pressure gradient. If they close the first step, we can identify if this shunt is correct or not. And we will do the portography and show it's a correct shunt. And the second one, they will measure the pressure gradient. If the pressure gradient after the closure is still under the 15, so they will close the shunt. And then you can see after the transplantation shows a good portal flow, the shunt is disappear, and it shows a very good portal inflow. And this is the case. And the second one I want to talk about how to do the portal vein stents intraoperatively. Like this case, this is a post-liver transplantation and with portal vein thrombosis. And sometimes we can reconstruct the portal vein, but we find if we, after the liver transplantations, reconstruction rate is about below to the 40%, but intraoperatively we can 100% successful to this procedure. So after then, we will do the intraoperative portal vein stenting instead of the after liver transplantation. And the first one is what is the indication for the intraoperative portal vein stent? And actually, they have some risk factors for the portal vein complication during the liver transplantation. And the most important is the previous portal vein thrombosis, like our first case is a portal vein thrombosis case. There will be poor quality of portal veins, and after the anastomosis, they may have a good high chance to induce the portal vein thrombosis after liver transplantation. And the second one is when the small baby with a small size of portal vein, a large GRWI, like the baby is too small, the graft is too large, or the baby is less than 8 kilogram, there will be high risk to be after the portal vein anastomosis. The portal vein will be kinking with a poor angulation and induce the portal vein thrombosis. In this case, we were to stay on call to OR to put the portal vein stent. And intraoperatively, what is the indication for the portal vein stent placements? The first one is total occlusion, and the second one is when we do the intraoperative portal vein sonography and then show the slow portal inflow. Less than 10 cm per second. This case may be high instance after liver transplantation. They will have the portal vein thrombosis, so we will do the portal vein stenting. And the next one is acute angulation. Sometimes the good flow, sometimes it's poor flow. In this case, we will do the portal vein stent to correct its angulation. And this is the case we put portal vein stenting. And you can find in the pediatric patients, we use the portal vein pivot stump approach is major. But in the adult, there may be verified approach way. Most commonly, we use the jejunal vein IMV to put the angiocyst and then do the forward stenting. But sometimes in a difficult case, we will use the direct puncture go test or from the liver surface. Like this case, our first case, we use the IMV approach, and after guidewire put into the liver, and you can put a stent, and after stent, make a very good portal inflow. And after then, we have one case is when the patient, we use the IMV approach, but the angulation of IMV to the main portal vein to the intrahepatic portal vein is too acute angulation. We cannot pass the guidewire into the liver. So after then, with this case, we shift the portal vein stenting from the pivot stump. The pivot stump means when we take the liver graft, we will leave the small stump of the segment portal vein and use this segment portal vein. We put the angiocyst and then put the portal vein stenting. Like this one's from the surface, the cutting surface with a small pivot stump. And use this small pivot stump, we can put the guidewire into the SMV and then put the portal vein stenting. This pivot stump approach is very easy to do, and we make the 100% successful rate for use this method. And sometimes not so easy, but in this case, CTA shows he received the sclerotherapy, and they occlusion the collaterals and the main portal vein, splenic veins, only patency of the IMV. And the surgeons, we use the intraoperative portal ground to make sure the IMV flow, the direction, and the direction is make the direction, and the surgeons elongate the inferior mesenteric vein and hydrophilic. After then, there's reconstruction the portal vein. But you can see these pictures. The reconstruction inferior mesenteric vein is very thin and cannot support adequate portal flow. So we use the pivot stump approach to put the portal vein stent. You can see the stents over here. inside the inferior mesenteric vein. And then so we put a stent from the inferior mesenteric vein to the graft portal vein. And this is for pediatric patients, but in adult patients, they usually has more complicated than pediatric patients. Like this case is a retransplant and the portal vein thrombosis, occlusion, and the poor quality of the portal vein. So sometimes we will use the gold test as a vein graft from the sphenic mesenteric junction to the graft. In this case, usually induce the angulation and the kinking of the portal vein between the gold test and the negative portal vein and the graft portal vein. So we use the direct puncture of the vein gold test. We take the gold test and use the IC direct puncture and do the portal vein ground and put a guide wire into the graft and put the portal vein stent. Actually, sometimes they have both the graft side and negative sides cannot be angulation. So usually we put two stents. One is into the graft side, one is into the negative side. Just change the direction, and you can to the negative side. So like this way, one is from the graft side, and change the direction. You can use the side. And after then, they will show the good adequate portal inflow. And after the CTA, you can see the stent over here, and a very good portal inflow for this case. So the next one, I will show how to do, like this one's very tortuosity of the collateral, and you cannot pass the guide wire into the graft side. Sometimes you can use the direct puncture from the liver surface and use the sonography guidance and the poor portal inflow and the direct puncture. Then put the guide wire and then put the stent. During the time, I will say, and sometimes when you fail, you familiar with those approach where you can do the more adequate approach way and to put the portal vein stent to save the life. And for the long-term follow-up, and so the portal vein stent can be self-expandable, and we follow the times from the 2009 to until now, so 100% for the patency rates. And the 32 patients with intraoperative portal complication, they have 28 still alive now. Our conclusion is, I think intraoperative portal vein stent placement is very effective and the long-term listing treatment modality to treatment of portal venous complication. And before the intervention, we were planning the best route to enter the portal venous system. And the stent can be make long-term patency, deposits the growth of pediatric recipients, and the cross operation can experience the indication for liver transplantation. Portal vein thrombosis, not the contraindication for the liver transplantation. And this ways get the annals of surgeon, the top journal of the surgery, and say write a completatory on our technique. And our boss is here. And thanks for everyone's attention. Thank you.